absolute pleasure of guiding you through this seminar. It would be wonderful to get a sense of who's here. So maybe if you want to introduce yourselves in the chat function and say hello there. But before I go through what we will be doing today, let's start to look at a video.
Mental health and psychosocial needs may be less visible than physical needs, but they are no less real, urgent, or life-threatening. Mental health conditions are among the leading causes of disability worldwide. However, globally, 80% are without any form of quality, affordable mental health care, and every 40 seconds someone dies by suicide. During armed conflicts, natural disasters, or health emergencies, the need for mental health care and psychosocial support increases dramatically, while existing support structures are often strained. For too long, mental health and psychosocial needs have remained hidden because of the strong stigma around mental health conditions, limited access to services, lack of workforce capacity, insufficient resources to address the needs, and a lack of global prioritization. Mental health and psychosocial well-being is critical for people's ability to live a meaningful life, perform daily tasks, and care for themselves and their family. If we don't react to the extensive unmet mental health and psychosocial needs around the world, there may be long-term human, social, and economic consequences. While most people show resilience, focusing on early and appropriate mental health and psychosocial support can prevent distress from developing into more severe conditions. The International Red Cross and Red Crescent movement recognizes the urgency to increase attention, meet needs, and bridge the gaps in mental health and psychosocial support. And that's why we, in December 2019, made historical commitments through a global policy and a framework to build a more harmonized, integrated, contextually appropriate, and holistic response to mental health and psychosocial needs, and a resolution adopted together with states to address the specific mental health and psychosocial needs of people affected by armed conflicts, natural disasters, and other emergencies. The policy and the resolution offer help and guidance to you in the context where you work. Together, we can increase action on mental health and psychosocial needs. Get more information at www.pscenter.org.
Okay, so I've seen that there have been a few more people jumping in, so I'm just going to do a quick introduction again. My name is Vera Carlbaum-Wrennmark, and I have the pleasure to moderate this seminar and to sort of guide you through it. Wonderful to see you engage already in the chat. Please say hi, introduce yourself so we get a feeling of who's here. And if you during this seminar, if you want to say something, share something during the smaller sections, you're very welcome to use the raise hand option, which you have under the participants symbol. And if you have bandwidth, you're very welcome to have your video on so we can see you. So the purpose of this seminar is to learn more about the Red Cross Red Crescent movement policy and the International Conference resolution on addressing mental health and psychosocial needs. We are not going to go into detail, but we really hope that this will be a meaningful conversation which will support you and encourage you to further engagement. And so, how are we going to do this?
Ciao, ho visto adesso la tua mail. Bene, facciamo questa modifica per
Yourself?
favore.
Someone's, perfect, thank you. The seminar is divided into three different parts, three sections, and I will do my very best to sort of bridge you through them. First, we will look at the policy, then we'll take a look at the framework, and lastly, we'll look at the roadmap. And as I mentioned earlier, we really want this to be a conversation. So please raise questions in the chat, examples and reflections. And Sarah Harrison is there to guide you through the chat. Okay, let's get started then. With that, I'll introduce Melanie. The floor is yours.
Hi, everyone. So my name is Mel Powell. I'm a technical advisor at the Reference Centre for Psychosocial Support and also a mental health psychosocial support program manager at the Icelandic Red Cross. So welcome, everybody. Good morning, good afternoon, good evening, all around the world. I see we have over 50 participants, which is great. And we had a seminar this morning, which also had more than 50. So that's at least 100 people from our national societies just here on the English version of this webinar. So welcome, everybody. So what I'm going to talk about in this first session, as Vera said, is I'm going to go a little bit more in depth about the policy specifically. So in particular, what does the policy actually mean in practice? So to just give us an overview of the policy, I know some of you have read it in detail, others not so much. We're just going to watch a short 2-minute video, which just gives a very brief overview. So Vera, if you could put the video on for us, that would be great. Great.
Everyone should have access to quality mental health and psychosocial support. That's why the International Red Cross and Red Crescent movement in 2019 adopted a joint policy on addressing mental health and psychosocial needs. The purpose is to enhance action by providing overall guidance on how to build a more harmonized, integrated, contextually appropriate and holistic response. The policy is applicable in all contexts and at all times and guides all national societies, IFRC and ICRC, in their mental health and psychosocial support work through 8 policy statements. 1. Ensure impartial access and prioritize prevention and early response. 2. Use a person-centered and holistic approach to addressing mental health and psychosocial needs, as these needs may vary greatly from person to person. 3. Ensure diversity and participation of people with mental health and psychosocial needs in all activities. 4. Protect people's safety, dignity, and rights. 5. Address stigma and discrimination. 6. Well-intentioned but ill-informed action has the potential to cause harm. Always ensure evidence-informed mental health and psychosocial support. 7. Staff and volunteers might also be exposed to distressing experiences and situations of high stress. Protect and promote the mental health and psychosocial well-being of staff and volunteers. 8. Human resources are the most valuable asset of mental health and psychosocial support services. Therefore, the policy also suggests developing the mental health and psychosocial support capacity, competence, and motivation of staff and volunteers. Together, we can increase action on mental health and psychosocial needs. Get more information at www.pscenter.org.
Great, thanks, Vera. So hopefully that video gives you a very brief overview of the policy. Now, I have just been on far too many Zoom calls, just at all. And also I've been on too many Zoom calls where we haven't allowed the audience to participate. So what I want to do in my session is I want to open it up for anybody, any staff or volunteers from national societies, IFRC or ICRC, to make a short intervention or a comment, 2 to 3 minutes long, about one of the policy statements. And there's 8 different statements. And you could tell us in your own words what that policy statement means, or maybe you would like to describe some of the work that you've been doing within the Red Cross Red Crescent movement as it's related to one of the policy statements. So I'm going to give you a little bit of time to think about that intervention, and you can either raise your hand in the chat and I'll see how many I can get to in this short 15 minutes I have, or just type it in the chat as well. I know myself, one of the best parts of Zoom meetings is actually the chat. So for me, I get a lot of resources out of the chat. I get a lot of interesting ideas from other people. So please do use the chat. It's there for us all to learn from. So I'm going to give you a bit of time to think about what you might like to say. And while we're doing that, I'll just explain the policy in just a little bit more depth. So Vera, if you could just bring up the slide that refreshes us on what the 8 policy statements are again. So as we heard in the video, the policy is applicable in all contexts and all situations. So this includes emergencies, disasters, conflicts, and also the everyday situations in which we do our work as a movement. And it also applies to all national societies, the IFRC and the ICRC. And we all have different responsibilities related to mental health and psychosocial support. And these vary, and they vary in accordance with what our auxiliary role is, the different needs or gaps that we've identified in the context that we're working, and also the different resources, capacities, or expertise that we might have in our different national society or in the ICRC or IFRC. So what this means in practice is that actually no two national societies or organizations will likely be doing exactly the same thing because we work in different contexts, we have different auxiliary roles, and we have different resources, capabilities, and expertise. And actually, this is another reason why the policy is so useful, because it helps us as a movement to work more coherently and more efficiently together, because we're working from a single policy to ensure quality mental health and psychosocial support. So that's just a kind of a brief recap of the policy, and Sarah Harrison has put in the chat where you can find all the documents related to the policy. So while you're just putting your finishing touches on what you might like to share with us today, I would like to open the floor. And first, if I could open to Dr. Fathi. Do I have you online, Dr. Fathi, from the Palestinian Red Crescent Society?
Yes, hi everyone.
Hi, welcome Fathi. It's so lovely to see you.
Thank you. It's my pleasure to be part of this seminar actually.
And it's our pleasure to host you, Dr. Fathi. You have a wealth of experience, and I know that the Palestinian Red Crescent Society has been doing a lot of work in mental health and psychosocial support. I was wondering if you could share with us something that you've been doing related to the policy and to one or two of the particular policy statements.
Yeah, first of all, Liani, thank you so much for everything, and thanks for those who were working really hardly in developing this strategy. And I think we were waiting for a long time to have such as really a strong strategy to give us or to push a little bit our work, because we were fighting from the beginning within Palestine Red Crescent Society to integrate mental health into our activity, and it was a little bit, frankly say, difficult because we were focusing in psychosocial, and the needs actually in Palestine, it's really huge. And from the beginning, we were really fighting to have or to integrate mental health. It's not only the psychosocial. The policy, it helps us a lot. And I can say that as the agreement was taken, let's say, or the resolution, it was signed, it gave us really a chance to revisit our psychosocial strategy and to have it like a MHPSS strategy now. How it helped us, I think that helped us in 3 levels. First of all, to be able to convince our management and to agree that yes, it's our role. It's not only the role of the government, and it gives us more space or a window to work through. The second issue that it gives us more to focus in the needs of the people in a holistic approach. It's not only that we are working in the first or second level, but now we can really reach the fourth level of intervention. I will give a little bit of our experience mainly with staff and volunteers. I think that now we are working in 5 different areas, let's say. First of all, that now each and every volunteer or staff coming to be a part of the national society, he or she have to go through 3 days trainings, basic training in psychosocial, just to understand the meaning of the importance of the psychosocial, to be able to help himself, and also to be able to take the psychosocial into account when he is or she is doing any kind of work in his own local community. The second issue that in each and every district now, we have a psychosocial worker that he is working on a daily basis with our staff and volunteers, especially in the last 1.5 years, that it was a little bit politically, and because of COVID-19, also the needs it became more and more for the staff and volunteers because what they are doing and let's say the load of the work that they are carrying in their shoulders. The third issue that we have now 10 24 hours phone numbers that each and every volunteer or staff, he can get back and to talk and to ask and to take some kind of guidance, let's say. The fourth level of intervention that we are doing with staff and volunteers, that they are able also to benefit as a family. It's not only themselves, but even if there is any kind of needs related to the family of staff and volunteers, also they can ask for us, such as help, because now we have at least 5 mental health workers who became a part of, they are volunteers, and they are a part of the family, let's say, of the psychosocial department, that the people, they can get back to them and identify some specific times to share or to discuss their own difficulties or problems. The other issue that now we develop also, or we focus more in ongoing training or capacity building for the whole staff and volunteers. It's not just the basic training that we were talking about. Also, in a yearly basis, there is some follow-up training for all staff and volunteers to be sure that also they have this chance to talk about themselves or about their own difficulties, and also to gain some new techniques to be able to use it with their beneficiaries, even if they are staff, if they are working as MTs or disaster workers or whatever. What's the areas of their work. This is in a hurry because you were talking about 2 or 3 minutes. I don't want really to take more. But definitely, if you feel that I have another time, I am pleased to share what we have.
Thank you. I know it's so hard to keep what we have to say in such a short space when we're working across all of the 4 areas of the MHPSS framework that you mentioned and the protective circle, Fathi. And our colleague today, Zara, is going to go into that a bit more. And I think it's really important what you highlighted there, that the benefits of having the policy, that we have all been waiting for it as a movement, and now it gives us more push for our organizations to do better, to do more, to work more collaboratively. And I think this is really important. And you were talking there specifically about policy statement number 8, which is about staff and volunteers and building their capacity and ensuring that they're well qualified to do the job that they do. And thank you so much for those examples. I think it highlighted lots of the different levels that we can do this at to make sure it's a holistic approach, that we do have the correctly qualified and the correctly supported staff and volunteers. And I would love to hear so much more. So please do put some more in the chat, Fathi. And is there anybody else who'd like to tell us about one of the policy statements as it relates to their work? And please just raise your hand in the chat. I'm going to scroll down and see if I can see any hands raised, or type in the chat. Okay, I can't see any hands raised.
Yeah, it
Maybe-
looks like Chime wants to say something, maybe.
Yes, please.
Hello, friends, many familiar faces. I would like to tap on what Fatih has just said, because I think that the COVID pandemic has proven as a very important opportunity for MHPSS. I know it sounds very strange, but I think that one of the challenges that we have all identified in the past is the issue of the silos. Mm-hmm. That MHPSS is a silo, that even though it is part of health, in many cases it is considered as something which is a little bit separated from clinical health and public health, and of course sometimes from disaster management. And then COVID came in and showed us all what an important impact the mental health and the mental health well-being of our staff and volunteers is important to what we are doing on a daily basis, regardless if it is community-based programs, visiting the elderly, working in institutions, or it is disaster preparedness, or it is health. And I would say it pushed very hard all the organizations to look into the aspects of MHPSS as something which is a core competency and core need of all our staff and volunteers, and how we need to integrate them better. Mm-hmm. And I would say, and how we need to understand the MHPSS needs of our beneficiaries as part of our, if I would use a disaster management term, the needs assessment. We are normally looking into food, shelter, and then we sometimes add to that clinical care. And now we are also talking about loneliness of people, the need to contact with others as essential needs of people that have to be addressed, and what we can do as the Red Cross movement, Red Crescent movement, to support those MHPSS needs. I think that it's been a good opportunity for us. We manage in a, I would say, an impressive way to leverage that. And I think that this is something that should be highlighted, because in many cases it is under the radar. It is an important change that happened, but we are not talking about it enough. Yeah. Thank you.
Indeed, I absolutely agree with that, and thank you so much. And I think you're talking there to maybe to policy statement number 1, which is about early and sustained intervention. And I think a lot of national societies and the ICRC as well is focuses on that, and it's really important that we're talking about early and sustained intervention, that we're doing correct needs assessment, and taking it forward through a professional approach. And as you mentioned there, it is indeed a core competency of the whole movement workforce. Anyone who has a client-facing role at all, needs at least basic competencies in mental health and psychosocial support. So I think I have time for just one more person who might like to say something. Maybe I can't see the hands raised, so if my colleagues could help me see if there's anybody who has a hand raised.
No one has a hand raised right now, but maybe.
Well, I'm just
dares to speak up.
I'm looking through the list. I see Stephen Wainwright is on the call. Could I put you on the spot, Stephen, and ask you to talk about protection, gender inclusion, maybe, and mental health and psychosocial support? I'm really putting you on the spot, or would someone else like to speak?
I'm happy to be put on the spot, as long as everybody excuses me for not making much sense. Any specific question, or?
Well, we have one of the policy statements that is related to dignity, participation, respect, and access. And I was wondering if you could tell us a little bit about, maybe give us some examples of what that looks like in practice, or how we might ensure that in our programming, or what that means to you.
Sure. I've got the wrong camera on. Hang on, I'm up here. I've been moving cameras around. Hi, everybody. Yeah, I'm Stephen Wainwright. I'm Social Inclusion and Protection Coordinator. And we've been working closely with the Peer Centre at the moment project on all of these links between what we call protection, gender, and inclusion that some of you may know about. And indeed, I don't know if you can just put the slide back up on the screen with the 7 headings from the policy, because there's something I did want to say in relation to those. And I have to just see where it's gone on my screen. Thank you. Thank you, Mel. Yeah, there's the particular one, of course, around the protection of safety, dignity and rights. I mean, and we're actually developing, as some of you know, the Protection Gender Inclusion Strategic Framework, a bit similar kind of process to the MHPSS development. And one of the key things is that MHPSS is an integral part, of course, of all protection, gender and inclusion activity. I mean, anytime there's abuse, violence, discrimination, or exclusion, that has a mental health impact, clearly, and psychosocial impact. So from that side, I mean, we've always been very clear and work very closely to see then how do we align these two so that any specific PGI activity, let's say, typically child protection activities, the prevention and response to sexual and gender-based violence. Any of these activities have a very deeply embedded MHPSS component, and we see trainings on a lot of those issues. Thank you, Sarah, for putting the acronym in the chat. I get used to saying it very often, but it's protection, gender, and inclusion. So that's on the side of the activities that we kind of lead on, right? That anytime we're addressing those issues of, let's say, violence, discrimination, and exclusion, which are the problems that PGI seeks to address, that we have MHPSS specialists to provide that input and provide that insight. Then on the other side, I mean, I think, and that was a big part of that development of the policy, was to say, well, within MHPSS activities is a bit the other side of the coin, that if you're looking as a psychologist, psychotherapist, or community support worker to look at what are the mental health issues that, or the psychosocial issues you want to address, very often those are linked to wider protection issues that maybe you don't have all of the experience or details on working. So in a nutshell, having been put a little bit on the spot, which I welcome, I mean, it was really very much about collaboration, right? And very much saying that there's two types of expertise, and we tried to bring them together as much as possible. One of the challenges then, which would be interesting if anybody would like to comment on that actually, is they are so similar sometimes that then it's a little bit difficult to separate out what is an MHPSS competency from what is a protection competency or an inclusion competency. And often they are very much the same, and we're sort of getting, I think, better and better at seeing when they are the same and when there's a difference. Of course, the higher up the pyramid you go, or the higher up the level of specialization you go, the easier it is to make a difference. Mm-hmm. And at the sort of lower levels of the pyramid, for those who are familiar with that framework in the policy, the more similarity we find. So it's questions of complementarity, questions of, at the same time, the great benefit is the complementarity. The risk sometimes is actually doing the same things for slightly different reasons, and then, there can be some confusions that arise because of that. But I think we're all extremely kind of aware of that now, and continually working really to make sure that the complementarity overrides any sort of risk of duplication or so.
Mm-hmm. Thank you so much, Stephen, and sorry for putting you on the spot. You were very comprehensive and coherent, especially for being put on the spot. And indeed, I think you're highlighting a lot of really important points. You're talking about the MHPSS framework, which is contained within the policy and the different areas of specialization, and highlighting some tools that are coming up from the protection, gender and inclusion area soon. And indeed, there is a lot of crossover and complementarity in terms of skills for an MHPSS worker and a PGI worker. And as you said, there's a lot of complementarity between the two.
And I'll just sort of conclude with one bit, taken from a webinar that was just yesterday with Marta, another colleague from the PS Centre. Mm-hmm. I was really, talking about how we embed MHPSS work in refugees or migrant support program, and made a great point that I shared with the NUC as well, see on that call. It's so nice to see that was one good example of supporting migration programs in national societies and how it was very unsiloed. Social inclusion programs are, of course, supporting of PSS, and PSS specialists can help make those social inclusion programs more effective. So one example, and then there's others from more emergency related programming. Maybe others have something to share on that.
Yes, indeed. Thank you so much, Stephen. And I think that might conclude my time now. So I'm just going to briefly sum up. So the policy, it's for all contexts and all situations. It's for the IFRC, the ICRC, and national societies. And today we're going to give you some examples of how to use it quite effectively. So next I'm going to hand over to my colleague Zara. And she's going to tell us about the framework, which some of the people who spoke just now referred to, and the different levels. So I'll hand it to you, perhaps Vera, to take it forward from here. And thank you, everyone.
Thank you so much. This is so interesting. I think it's really encouraging that this high-level document makes concrete and practical difference in our national societies. And with that, we sort of close this first part of the seminar and bridge over to talking about the framework. And I'm going to let Zara introduce herself, but first we start with a short video. Let's see here if I can get this right one more time.
In 2019, the International Red Cross and Red Crescent movement agreed on a mental health and psychosocial support framework, building on international recognized models and adapted to our specific mandate and auxiliary role. As you move up through the different layers of the framework, more training and formal education is required of staff and volunteers. The circle represents a safe and protective environment, which is the foundation for all mental health and psychosocial programs. That is, guaranteeing basic needs, human rights, and freedom from abuse, discrimination, and stigmatization. The framework tells us the best ways to address the mental health and psychosocial needs of individuals, families, and communities, where basic psychosocial support, the first layer, promotes positive mental health and psychosocial well-being, resilience, and social interaction within communities. Activities are often integrated into health, protection, and education, and should be accessible to 100% of the affected population where possible. Actions to support people in distress can be group discussions, individual interviews, recreational activities based on skills such as active listening, group facilitation, or psychological first aid. Focused psychosocial support, the second layer, also promotes positive mental health and psychosocial well-being and includes activities to prevent further distress or the development of mental health conditions, with a specific focus on groups, families, and individuals at risk. Activities could be peer support and group work. Psychological support, the third layer, includes prevention and treatment activities for individuals and families with more complicated psychological distress. Activities in this layer could be counseling or psychotherapy, which are usually provided in healthcare facilities with accompanying outreach work or in community facilities. Specialized mental health care, the top layer, includes specialized clinical care and treatment for individuals with chronic mental health conditions, and for persons suffering such severe distress and over such a period of time that they have difficulty coping in their daily lives. Activities could include treatment centers for survivors of torture and alternative approaches to drug therapy. Services in the top layer are often provided within state healthcare and social welfare systems and in detention facilities. This multi-layered approach does not imply that all national societies, IFRC and ICRC, must provide services in all layers. However, we are all expected to assess, refer, and advocate across the full spectrum of the framework. Together, we can increase action on mental health and psychosocial needs. Get more information at www.pscenter.org.
Thank you very much, Vera, for showing the framework video. So as you could see, this is the framework. This is actually where we can focus on what can we do as national societies, as the IFRC, as the ICRC. It really reflects the different layers and the different activities that we could possibly conduct. I think it's important to start with mentioning again the protective circle around the pyramid. It is important that we can ensure, similar to what Stephen was talking about, that people have access to services, that they are treated with respect, that their safety is ensured, and that they know their rights. I think it's also important to mention again that when we look at this, we might be a bit overwhelmed and say, oh, these are, I mean, how can we possibly implement all of this? But actually, the good news is we don't all have to do all of this, but together we should strive to ensure the continuum of care, right from basic psychosocial support through to mental health services, the specialized services at the very top. So I think that's also important for us to know. And what we really need to be able to do as a national society, if you're just starting up, is to be able to assess the needs, to refer to relevant services, and also to be able to advocate for those services to be provided to an affected population. And I think one of the important differences from this framework that we have now as a movement compared to the interagency standing committee pyramid that many of you are familiar with, is that our framework is not just for emergency settings, it's relevant for individuals, families, communities in all settings. So from Trinidad and Tobago to Canada, to the Philippines, to Belgium, it's relevant for all of us. I would like to take this opportunity to speak more concretely now about the different levels. So Vera, if you could again put up our brilliant framework. Thank you. And while she's doing that, the first level is the basic psychosocial support. This is indeed the level that we encourage all national societies to be able to provide. It should reach the entire population. So this is for 100% of the population, as you can see, and then it goes upwards. So the higher up we go, the smaller percentage of population, and it goes up to more sort of group focus, to more individual focus. When it comes to the promotion of mental health and psychosocial well-being, this is really where we start from. And at the basic level, it's very smart to try and integrate services with other programs. So for example, you could look at if you had a first aid program, you could also train your first aiders on psychological first aid, for example. You could do dissemination of relevant information on mental health and psychosocial support. And I think I'd like to bring in now Yulia. Are you with us? From the Ukraine Red Cross. It would be very good to have some very practical examples of how you as a national society are implementing activities on this level.
Thank you, Zara. Hi, everyone. My name is Yulia. I'm representing the Ukrainian Red Cross Society. And on the level of the basic psychosocial support, we are conducting trainings for the population, training them with a PFA as a basic model, as well as a PFA for children. Particularly, we are doing within the program Disaster Risk Reduction that is running on the East, where we have armed conflict. And it is a comprehensive program where PFA is implemented as a component along with first aid trainings and also trainings on biological and chemical hazards. So our trainers prepare community volunteers who would be able to provide PFA in case of emergency.
Great. So here you have an example of how it has been integrated within a disaster risk reduction program, and it actually focuses on different skill sets, so first aid and psychological first aid skills, for example. And this is exactly the kind of thing that as a national society you would be able to do if you have a more sort of long-term program running. It could be a CPHFA, nutrition. You can find ways to promote mental health and positive mental health and psychosocial well-being. Thank you. And when we go to the focused psychosocial support, this is for more at-risk groups, individuals and groups. And on this level, it also requires more training of staff and volunteers. And Julia, I think you also have an example here of a more focused activity. Some of you may be familiar with it. It's called the Children's Resilience Program. The Palestine Red Crescent for many years also implemented the Kabak program, which was also similar. So could you share a bit more about the Children's Resilience Program?
Yeah, we surely have the Children's Resilience Program that we're trying to implement along with all the manuals we have. We are running the program mostly within the within schools because it guarantees the stability of the group and somehow sustainability. We train both our Red Cross volunteers, or sometimes we recruit the school teachers as volunteers to guarantee the access. And we also adapted the program during the COVID-19 as a children's resilience program is could be nicely adapted to online format. That's it for everyone.
Oh, but that's very creative. And I think in general, the Ukraine Red Cross has been very creative during the COVID response, putting a lot of activities online, painting classes, recreational activities, and also being able to reach vulnerable elderly people in their homes. So I think for anyone who needs more inspiration on how to go online, do reach out to Julia. And here you have an example of where a well-trained teacher is able to conduct a weekly workshop with, let's say, 20 children, and she follows the same children over a period of time, for example, 20 weeks. I think when we then move up again to the higher levels, then it's even, shall we say, smaller groups that we are aiming to reach. And Julia, you also mentioned that you as the Ukraine Red Cross don't provide psychological services, which is the third level. However, you were able to, during the COVID response, ensure that you could refer staff and volunteers to psychological services. Could you tell us a little bit more about how you did that?
Yeah, we usually we are promoting the idea of support groups, so in peer-to-peer support among our volunteers. Though during the COVID-19 response, we faced higher demand on and more severe reactions, and we were not able to provide the group support offline. So then one of the projects on COVID-19 response, we launched the outsourced psychological service for our staff and volunteers. We signed an agreement with Kiev Institute of Psychology. they provided us with 8, I guess, or 10, 8 psychologists and 1 manager who was receiving all calls and set up meetings via Zoom or phone or Skype or wherever is needed between our volunteers and staff and their psychologists. And it was absolutely confidential. We didn't get any names or anything, just statistics on the number of calls and the geographical designated data. And it was for 6 months, and our volunteers received leaflets. We put posters in their rooms when they come together, so it's successful.
Great. And so here we have an example of, you can't do it all, but in this case you were able to ensure referral. As I think one of the things that I really love about our new framework is that it also encompasses more of the higher levels of the work that we do, and especially also through the ICRC. So I'd like also to welcome Milena to the conversation. Are you with us, Milena?
Yes.
Yeah. So good to see you again. When we speak about the psychological support level, I mean, this is more for individuals and families who are, presenting with psychological distress, and maybe they're more at risk of developing mental health conditions. I know that the ICRC has a rich experience working in different countries and providing psychological support, but indeed also training staff and volunteers in local communities, community members. So could you tell us a little more about that type of work that you do?
Yes, so using practical examples, which I think it's more helpful for everyone, I would like to refer to specific support services that we provide to victims of violence, for example, victims of sexual violence, and this includes children, to the weapon wounded, for example, and the persons that arrived in hospitals and in health facilities that are very likely going to be amputated. So they are going to have to deal with physical disabilities. It's a very, another important, I think, an extreme example. So what we provide to them is this psychological support, and it can be provided in a way that we see in two ways. Let's say that if we use the same analogy as with the psychosocial, we can talk about the basic psychological support or more kind of psychotherapy, as it was in the video, no? But both of them are equally important, and we actually implement both or one, depending on the context, on the cultural relevance of it, and on how the victims are responding to it. So that's to say that we work with counselors and with psychologists, but we also work with, it can be community leaders, volunteers, or staff that is trained in psychological support, in basic psychological support. Just the difference is that the training will be longer, and the monitoring and the coaching and the support that those persons will need, it's stronger, so that we ensure that there is no harm, and more importantly, that they know, because it's incredibly frustrating for volunteers, for staff, for community leaders to have to receive so many people that are severely affected and not know what to do and what's the limit, no? If you can harm. So I think our trainings focus very much onto, it's not again transforming them into psychologists, but it's actually building their capacities to provide this basic level. But we also have psychologists that provide psychotherapy and psychological support. I like to provide one example that shows for me not only the work, but the collaboration is, for example, in Central African Republic, in Carlbaum-Wrennmark, which is, I think, an interesting example, because as you said before, Sarah, in many of the contexts where we work, it's not possible to refer. No. We wish, right? But it's not simply to say, oh, we will refer. Many times there is just not this possibility, and we know that people struggle with an incredible amount of vulnerability. So in Central African Republic, we work with the National Society with children affected by violence. And what we do is basically, there are recreational activities, play activities, drawing activities that are taking place and run by the volunteers and by the staff of the National Society. And we are training them and supporting them so that we can go one level up at the same time that we have psychologists and we have counselors, so that enter into these activities, so they can also take care of the children that are more affected and that are identified in those playful recreational activities. No? So it's another example of how this psychological level can be integrated into our work. So it's indeed either we train, we coach, and we provide support. If we can refer, great, or we can also collaborate together when we know that some of our movement partners have actually psychologists in the field. I would also like to emphasize, as we saw this morning, that a lot of national societies do have psychologists. And so I think that this is, I think as Dr. Fati was saying at the beginning, no, for some of us, it's really so important to see this level integrated because what we feel is there is staff in the national societies that would like to know more and do more about this, and we haven't been able before to provide this. And second of all, we were also very concerned of a lot of volunteers and staff that are victims of conflict themselves, that go through an enormous amount of stress, and sometimes the psychosocial support is not enough. If we talk about people that are collecting dead bodies all day long, that cannot even eat because they cannot take away the smell of dead bodies around them. I mean, we are talking about very serious things into which we are very happy that we can start looking at as psychological.
Yes. Thank you so much for that. And I think, again, it's you're giving a very good example here of how important it is to be able to provide services at different levels, but also indeed that whether you might be an individual getting psychological support, but you certainly also benefit from being part of psychosocial activities, basic psychosocial activities or focused psychosocial activities. So one doesn't exclude the other. On the contrary, they complement each other, these different levels. I think that the very top layer, Milena, we often neglect it. We're a bit sort of, ooh, what is that? And I would like you to sort of demystify it and also speak to what I think is a lot of stigma around having, for example, a chronic mental health condition, and where people sometimes, I mean, refrain from accessing services that are there simply because of the stigma around it. Could you tell us a bit more about this, smaller population that needs access to more clinical care?
Yes, Sarah, thank you. So I think, first of all, let me use the opportunity. I know the time is brief. Indeed, I think this demystification of what this top layer is a big concern for us all. And even though many people think ICRC is very comfortable with that, not necessarily, right? We approach it with a lot of care. But I think the issue is, first of all, I would like to invite everyone to think that this specialized level is not equal psychiatry or not only. I think our idea of having this specialized level refers, for example, to initiatives like the awesome program that the Swedish Red Cross runs in the centers of torture and ill treatment, for example. So it's a multidisciplinary service when you have psychiatrists, you have psychologists, you have a physiotherapist, you have a social worker, you have a lawyer, right? So it's like a beautiful center when the person is taken in an integral way, and this is ensured. So that for us is on that level as well, no? So we are talking about a specialized service with a very specific focus, in which we can actually learn a lot from the experience of the Swedish Red Cross, and many other national societies do have this type of services domestically, and it will be very good for us. No, it's a dream. So the second thing is, as you said, I think the issue of stigma for us is incredibly harming today. We see a lot of people in conflict-related contexts where basically they are tied to their beds and the trees and tukuls and their houses. They are chained down, many treated like animals because they have a mental health condition, and there are no support services around. There is not awareness from the community. So basically the person is or possessed by the devil or has a contagious disease or should be as far as possible from society, which also actually contributes to having a lot of them inside prisons or inside actually institutionalization, because simply people don't know what to do with them. So it's easier just to block them somewhere. So I think the quantity of human rights violations that we see with this vulnerable group is huge. And I think that a part of what the movement wants to do, and that's what we also said, if you don't work on that level, let's at least don't forget the advocacy and the importance of this, which is making sure that we pass a message to the world, talking about the incredible vulnerability of these people around the world, and particularly in fragile contexts.
Yes.
Lastly, I would like to say it's not also that the ICRC, and I think in general, well, some national societies do. I think the Afghanistan National Society has some experience on this, and some others. But I think what we want to recognize, Sarah, is that even if we don't provide psychiatric support, advocating about this need, referring the persons, and actually discussing also with ministries of health and others about the importance of these services is extremely relevant today, and that we need to encourage, and we need all to be together as a movement, making sure that, you know, that we don't do what we preach not to do. We shouldn't do it also with people that suffer from mental conditions. No, I think this fear of touching this subject, because it scares a bit and is filling with taboos, shouldn't prevent us from actually making sure that this is also a part of a comprehensive MHPSS reflection, even if it's not a part of activities. No, so it's an invitation to think about this and contribute from that humanitarian point of view as well.
Thank you so much for those very strong key messages. And indeed, I think we all need to look at this wonderful framework that we now have. It's ours, and we can together, I mean, use it to analyze the needs, to assess our capacities, and what kind of skills are required to provide services on these different levels. And as Milena is saying, we can all, whether we are a volunteer, staff, you're an evaluation team, you can all use this framework in a very practical way. And I think I have to wrap up now, Vera.
Yes, you really do.
Yes, I could see from your body language, it's like, yalla.
Starting
so,
to...
yes, squirming. So I will wrap up here. And Dick, I think it's your turn to enlighten us a bit more about the resolution. Thank you.
Thank you so much. Yes, it's time. I'm going to pass the mic to Dick right away. I just want to see, how are you guys doing? Please write in the chat. How are you feeling? What do you think? Is it interesting? Do you have questions? Please engage in the chat. I would like to hear how you are. But Dick, go ahead. Take it away.
Thank you so much, Vera. Here is late afternoon and completely dark, and I hope it's so. Let's keep the energy and the warmth in this meeting while we're just online. No, thank you all indeed. And my name is Dick Clomen, and I've been heading the joint movement project on addressing the mental health and psychosocial consequences of armed conflict, natural disasters, and other situations and other emergencies for the past more than 2 years. And part of what we've been doing is really to develop this policy together with all of you and national societies. And the other half, or the main work, has been to develop a resolution for our international conference of the Red Cross and Red Crescent. And I think maybe I should just start there, because this international conference, which is a meeting place for not only the members of the movement, 192 national societies, the ICRC and the IFRC, but also 196 states, and in addition, a number of observers. But together with the states, since 150 years now, we actually have our own exclusive conference. And at this conference, we take joint decisions, and which are in the form of resolutions. And in 2019, for the first time ever, we selected mental health and psychosocial needs as one of the main themes of the overall conference. And as we could hear also today, and just given all the examples that we have heard and how important it is, and not least in the context of the COVID-19 response, we could see how extremely timely this was. The resolution as such is our joint agenda. So it could be used as a joint agenda for not only the movement, but also to partner with states. So in the advocacy work that you've been referring to this afternoon, use this resolution, because it's all there. And just to describe a resolution a little bit in essence, it contains of two major parts. The first part is a set of preambular paragraphs. And these preambular paragraphs are more kind of framing the narrative. It's describing the problem, but it's also agreeing on a few certain standards and practices, and also kind of recognizing facts. So the preambular part is very important, for example, in recognizing that states have the primary responsibility to address mental health and psychosocial needs, while the movement's work is complementary. It also recognizes that we should do no harm and that we should apply internationally recognized standards when we do our work on MHPSS. We should also work within the legal frameworks that there are, international humanitarian law, international human rights law, and so on. So it's extremely important, even though it's just a preambular. So just read it through and take a look. The other part is where we demand action, where we actually say that now you should act, now you should also address these needs. And so the second part of the resolution we call the operative paragraphs. This resolution includes 9 operative paragraphs, which actually ask the states and the ICRC and the IFRC and the national societies to act, to work. So there we have concrete political commitments, which are, I would say, binding to us as members of this international conference. And Vera, maybe you can just put up the slides which summarizes these operational paragraphs in essence. So on screen, you will soon see these operative paragraphs, which I have summarized into 7 points. But as you can see, they are very much the same as you would hear about the policy, because it's what we see is actually this is the way we want to address mental health and psychosocial needs. And the first one, where we have the action that we demand from states and the movement, is to ensure early access to mental health and psychosocial support. And we say that mental health cannot wait. It should be part of the first response, but also it should be sustained. So increase the action. The second point is really a matter of where we are as a movement, building on the local level of response, building on the community action, but also the proximity as the movement has in our emergency response. I forgot to say this also as part of the introduction. This resolution is really addressing situations of armed conflict, natural disasters, and other emergencies, but it could be equally relevant beyond these situations. But here we are focusing on the populations affected by these situations. In relation to the local and community-based response, we are also asking states and national societies and the movement components in general to partner to address these needs. Here you will also find a reference to the auxiliary role of the national societies in relation to their public authorities. The third point you can see here is also what we have been discussing in relation to the pyramid. When we discussed with governments how to frame with this, we wanted to be as concrete as possible. So we say, don't only address the psychiatric care side of mental health, and don't only address the basic psychosocial support, but have a comprehensive view when you address the needs. And also acknowledge that people might have different needs over time, and also they may have integrated needs. And that is also really what was well explained by Sarah and the others when you talked about the pyramid. So we say that we should include psychosocial, psychological, and specialized mental health care. The fourth point is a matter of the integration, and we have heard several examples of that already during this presentation, that we should integrate MHPSS into other activities addressing humanitarian needs. This includes also the systems, the emergency response systems and plans, coordination mechanisms, and so on. When we started to explore this globally, what we see also when we're looking on the needs globally, we can really see that one of the main problems is the lack of workforce. So we say that states in particular should invest in an increased capacity in the workforce to address mental health and psychosocial needs. Here we also include the valuable asset that we have, are millions and millions of volunteers working on the ground. So it's also recognition of the role of volunteers as part of that workforce. And the second last point is a matter of the stigma, exclusion, and discrimination, which we also find that if we don't address the stigma and exclusion and discrimination around mental health, we will not be able to be successful in our response. So that is also part of this. And finally, we come back to this so important matter of addressing the needs of those who are working to respond to the needs of others. And again, coming back to the COVID-19 pandemic, it has been so important also to work with the needs of those who are responding, to make sure that the mental health and psychosocial needs of the workforce, including the volunteers, is protected. So that's the essence of this resolution, and we really encourage you to use this in the dialogue with your public authorities and with the governments, and also to disseminate it and to show that this is what we have agreed in 2019, and this is our joint agenda. Now I'd like to invite Vera, if you can just stop the slide there, and invite Dorothy Anjuri, who is the focal point for MHPSS in Kenya Red Cross, but also the health manager, to just maybe you can share a few examples of how you have been working in the Kenya context together with the public authorities in relation to COVID-19 and the current response as an auxiliary to the public authorities, and maybe also addressing the first kind of the early action and the local action and community-based action. So, Dorothy, could you please?
Yes, thank you, Dick, and good evening, good morning, good afternoon, everyone. Okay, for Kenya Red Cross, we have been working very closely with the government, particularly the mental health division, where the mental health and psychosocial service provision sits. And what we did is that because we are one of the core and the strong partners who work with the ministry, Kenya Red Cross was considered as a core or as a preferred partner when it comes to the response for COVID-19. And we formed through of course, the government, we formed a mental health and psychosocial support subcommittee where we ensured that all partners doing mental health services come on board so that we can be able to synergize and collaborate in a more concerted effort. But over and above, we have been also working with the government to ensure that there are standardized training curriculums, especially in the context of COVID-19. For example, the PFA manual, which was customized to mirror the COVID-19 context, and we have been supporting the government and other partners in terms of training people on PFA to be able to respond to COVID-19. We have also been having regular meetings with the Ministry of Health, again, to be able to take stock of what we have been doing as an organization, which is championing mental health across the country. And we have been talking quite a lot with the Ministry of Health. Again, this has not been I cannot say it has been an easy thing before, but it has taken us lobbying and, of course, having targeted meetings with the authorities to ensure that we are all speaking the same language, and also to ensure that the Ministry of Health is taking the forefront in terms of the response for COVID. I will say that before this was not the case. I know Chaim talked about COVID is a blessing in disguise in the context of mental health. It is also true for Kenya. I can tell you now that mental health has been prioritized and is up on top of priority for the government. And this is what everyone has been praying for. And we are hoping that even moving forward, this momentum will be maintained. Coming back to issues around the early access and early access in terms of mental health and psychosocial support in the context of emergencies, Kenya Red Cross, again, through the collaboration with the Ministry of Health, we always do early planning. And early planning means that we are also sitting on the table in terms of the disaster management authorities that are within the country. Internally, also, we plan with our disaster management department to ensure that even as we are planning for any kind of response, then mental health is also prioritized in the planning. When it comes to activating our Red Cross action teams and volunteers spread across the country, then again we ensure that these teams are well capacity built in terms of having basic skills on PFA so that they can be able to support in the event that there are these disasters. Then again, what we normally do is we ensure that through collaboration with the government, we have, the county governments across the country also activated so that they are able to be ready in terms of mobilizing resources, mobilizing, human resources and financial resources, ensuring the structures are also, functional in terms of, any eventuality of mental health and psychosocial support needs, and also ensuring that the referral and the linkage services are there to be able to ensure that then we have a complete referral and linkage for any, provision of services that would require any referral, as it were. So again, ensuring integration, and I like, Dick, what you talked about. Integration is very, very key. In terms of ensuring mental health is not left behind. And the other thing for Kenya Red Cross that we have done is ensuring that we mainstream mental health and psychosocial support in all the programs, whether developmental or emergency context. And then I think the big win for us has also been the support from the senior management, which has also taken mental health and psychosocial support as a core component in terms of our programming. And this has been a big win for us, even not only within the organization, but even outside the organization as we work with the other partners. Over.
Thank you, Dorothy. That was really rich, and I think we will have a lot of examples probably from the participants here, but we don't have the time to go through in depth. I know that many of national societies are also struggling with the resource mobilization as part of this, and maybe that could also take us to the last part of this webinar. Vera, if you allow, maybe I can just take us there, because now we have the adopted the policy, which is very comprehensive, and it actually covers the work that we do in a very good way. We have a resolution, which is our joint agenda with state, which is a very strong advocacy tool for all of us. And we have, as Dorothy also says, we have now the ears and eyes of our leaders within the movement. And I think that is a critical part of the whole engagement and all the efforts that are happening right now. It's when we have the attention of the leaders, we will also be able to move forward and taking the next step. After the international conference last year, we were tasked also to develop a way forward as a movement. And so the ICRC, the IFRC, together with national societies, met again and they said, now what? We have all of these instruments, and it's very detailed and it's very rich. How do we develop a kind of a joint roadmap to make sure that we set a few priorities, not to go all over, but just to set a few priorities for the coming 4 years? So we have developed a roadmap for implementation for the period of 2020 to 2023, and you will find it on the PS Center's webpage, and we will share with you the link just in a few minutes. In this roadmap, the kind of the backbone of the idea was I mean, really the idea of making MHPSS as part of our core identity. So as first aid has always been part of the emblem of the Red Cross and Red Crescent, we should now also say that let's make MHPSS as part of our ID and our brand as a movement. And how do we get there, and how do we really implement? So we said let's find 6 priority areas where we can work together and really to take the crucial steps towards full implementation. And let's make them strategic, as strategic as we can. And here you can see, and this is part of the roadmap, you can see on the screen right now, is what we defined as the expected outcome for the 6 priority action areas. And in the first one, you can see that we will invest in the basic level of psychosocial support. We want it to be established in all national societies, the IFRC and the ICRC. But we also want MHPSS considerations to be integrated into other humanitarian services. So that is the first goal. Under each priority action area, we are now forming a working group where all of you can actually join in. So when I now present this, just think about where could I tap in, where can I follow, what can I work in the future. And the second area of work is where we wanted to invest in a few contexts to show and work on more on the comprehensive, the full pyramid, so to speak, the full framework, and see how we can work in it, not all over the world, but in a few cooperation contexts where we can actually see where we can invest more holistically. The third priority action area is around the mental health and psychosocial well-being of our staff and volunteers. And here we define it as we want to create this supportive and caring working environment for all. And again, I mean, I can just see this year how important it is that we support each other, but also that we have the right skills and tools to take care of ourselves. In the fourth area, it's a matter of showing the impact of our interventions, but also be using innovative approaches and also to do research to be more efficient and effective in the future. So we want to continue to develop mental health and psychosocial support interventions, but we also want to document them and communicate them with the outside world to show that we are actually having an impact. The fifth and the sixth area is really a matter of the dialogue with donors and states. Regarding the fifth area, it's a matter of increasing our financial and human resources for MHPSS. And this is a main challenge for so many national societies, but also for the IFRC and ICRC to really make sure that the MHPSS funding is there. So this is why this has been selected. And the last one, we're talking about advocacy, humanitarian diplomacy, where we really want to make sure that we use the resolution that we have developed as our tool to advocate with states. So that is in essence what we have developed in this roadmap. And in this roadmap, you will also see the elements of championship, leadership, communication, and also continued dissemination of this instrument, and as we are doing right now. But I would like to maybe invite a few other voices. I don't know whether, for example, I can't see all participants right now, but I was thinking about Marina from the Netherlands. Are you with us?
Yes, I am, Dick.
Hi, Marina. And so maybe you could just, you are lucky to come from a country where your government has been really, really supportive of MHPSS over the last 2-3 years. But maybe you could also see how can we find the synergies now when we have a roadmap and how we can work together on this.
Thank you very much, Dick, and greetings to everybody. Really nice to see, and thank you for organizing this. Just on the work that we have, and indeed we are lucky that we have a couple of champions in the Netherlands and in the Netherlands government with whom we've been able to work and continue to work. And I would say that collaboration has been there some time, where we had conversations to begin with, changes where we were asked to support with consultations for the MHPSS summit that was held last year. So the emergency MHPSS in emergency context. But also we work closely looking at the pledge. So that was particularly the PFA pledge, but also in other preparations for the international conference last year. So there continue to be moments where we are engaging or exchanging, for example, also when they were preparing for advocacy high-level meeting in New York and other places. And I think that continuous dialogue that is there, I would say with the movement, because obviously there are many channels of conversation, but it has helped both Netherlands Red Cross and I'm sure also from government side to stay informed about what are the issues and what are we grappling with, and especially on the advocacy. So I think this is really a very important role for the states, and in this case for also Netherlands government to pick that up. So our work has been around informing, exchanging, also inspiring, I think inspiring each other, reminding each other of the issues and continuing to be linked in terms of the work. So I think that's where we can learn from, and we try to engage as much as possible, and hopefully we can all work towards that. And I think the challenge is to sustain it. So I think this is really what we need to work on in this, of course, the next 4 years following the resolution, but also afterwards. So yeah, I don't know if you have a particular question that you still want to ask.
No, thanks, Marina. I think you are covering, I mean, the importance of not only working with movement partners, but also engaging the states as parts of the conference, and also those who once actually created the movement with states together with some private initiatives who created the Red Cross and Red Crescent movement. And I think that's what we need to work with, but we have to diversify these champions. And I think your government is an excellent example of one government, but we need more governments, and we need all of you to partner with your governments and use these tools to move the agenda forward, but also partner with other organizations, of course. So thank you, Marina. And maybe just I can turn to Sarah Seiberg, also maybe to elaborate a little bit on this first priority action area where we talk about the basic and again coming back to integration and basic psychosocial support across the movement.
Yeah, no, I think for the priority action area 1, this is really where we all, especially, I mean, as national societies, can contribute. And I think if we could all ensure that we were able to provide this basic level of psychosocial support, we would come a long way. And I see it as having many opportunities, really, because you can link it to other more long-term programming that you might be having. So even if you are a small national society, you're just starting up in terms of mental health and psychosocial capacity, and you're feeling that it's a bit of a daunting task, but you can actually link it up to, let's say, if you have an ongoing CPHFA program. So I think there are many opportunities here, and through integration, I think it's also integration of activities into other sectors. I think it's very important to do that, as Dorothy was also saying, because this is one excellent way also to reduce stigma around mental health and psychosocial support. So for me, when I look at this and the national societies that I have the privilege of working with, this is really the priority action area where you can really sort of get started and make a difference here and now.
Thanks, Sarah. I think what we also need is a lot of good examples of how we do this in practice, and continue to share, but also continue to tell the stories, because it's the stories that are so powerful and what we have actually achieved. Yes. And to me, as a fairly new person in MHPSS, not being an expert, I feel that all the stories that all of you have is what is also carrying me forward. And this is also what are convincing states and the movement internally to prioritize mental health and psychosocial support. So we need, as part of this roadmap, also to continue to collect data, collect the stories, and also making these stories available to those who we want to influence, who we want to keep on supporting our work. And I think with that, that concludes very much of why we have this roadmap. Again, I'd like to encourage everyone who's participating here to see how you could contribute to the implementation of this roadmap and then the policy, and use it in everyday work, and also the International Conference Resolution, which is primarily for the states and the organization and such, but it's a tool. And I think with the roadmap, which is available will be available soon in all the languages, but it's already now in English at the Peer Center's webpage. Read it and use it. And when we now start these working groups, probably early next year, there will be a call for invitation to all of you to participate in somehow. Use that opportunity to contribute to the implementation of this. With that, Vera, I'd like to maybe hand over to you to wrap up a little bit.
Thank you. Thank you so much for this. This is, I think this is exactly the conversations we need to have. This is my biggest takeaway from this, is that we are already doing so much, and we're all playing for the team here, for the same team here. This is really a team effort where everyone has a certain role, and the roles are different depending on who we are and what we do in this movement, but our roles are equally crucial in order to succeed. So I hope you guys feel as empowered and inspired as I am. I will go on and take on this work through the work I do in the IFRC Youth Commission. Mental health is one of our 4 priorities, and we are now forming the project called, it's a declaration on mental health awareness, which where we engage youth all over the movement. I think this is, and it's a perfect example of working from where we are and doing whatever we can to make a difference. So before I say goodbye, I would just like you to share what's on your screen now, hopefully, if I did this correctly, where you can the resource room, which is provided in the chat. It's also where I showed all the videos during this seminar, and on psccenter.org. So with that, thank you so much, everyone, for being here, and stay safe and take care.
Vera,
yes.
Sorry, Sarah Harrison, who is managing the chat, wants to say something. And
sorry, I can't see anything now.
No,
I'll stop sharing.
Sorry for interrupting, Sarah.
Sorry, one of the problems if you're co-hosting a webinar is you don't have the right to raise your hand, which is a problem if you're moderating the chat. There was just one thing that came up in the chat, which I think is quite interesting because we've not heard it before, and it's from Psychosocial. I'm sorry, Psych, if I've pronounced your name wrong. And I think it's particularly interesting because it's with regards to developing a professional workforce for MHPSS, which we also have in the roadmap. And she was saying that particularly in the eastern part of the world, so she's referring to the Asian context, it's not just us, but there's also a need to reach out to educational institutes, universities, so that they can also ensure that training programs are available for people, and that training programs and qualifications are recognized, and that they also have got a link to our humanitarian work as well. That was
wonderful.
I hope I got that correct.
Ignoring you. With that, I think we're ready to say thank you and goodbye. We'll sticking around here for a few minutes if anyone wants to say something to conclude or raise something in the chat. Thank you so much for participating. Let's get to work, guys. Bye.
Hi, thanks so much.
Thank you.
Thanks. Bye-bye.
Thank you. Bye-bye.
Bye-bye.